All right. Good morning, everybody, and welcome to the opening plenary session for day 2 of the 3rd annual USAID Office of HIV and AIDS Local Partners meeting. We're presenting a session today called Dueling Crises, Pandemics, Political Crisis, and Human Rights. In this session, we're going to attempt to address the duality of crises that are facing USAID PEPFAR local implementing partners throughout the world. And as we know from the past year, that beyond the dual health pandemics that we have, HIV and COVID, many of our partners and beneficiaries are also experiencing other crises related to human rights, mass population movements, political and civil unrest, and more. Today, we have the opportunity to openly discuss how these conflicts are impacting our USAID work and how USAID and local partners can collaboratively come together to address some of these pressing issues. Today, we're just really pleased to have 4 distinguished panelists from around the world who are going to help us discuss how USAID and our partners are responding to the number of crises that are being experienced in their countries and throughout the world, as well as raising potential innovative solutions to mitigate the impact of the events on our HIV programming. Just a few logistical matters. If you have any questions, please put them in the chat and we'll endeavor to address them after the panelists have made their initial statements. You can put them in the chat again and they'll be passed on. This meeting is scheduled for 1 hour and 10 minutes, and we hope to elicit some thought-provoking discussions as well as solutions. I'd like to introduce our panelists today. Our first panelist, Jeremy Konondike, is got an impressive resume. He serves as Executive Director for the USAID COVID-19 Task Force and is a Senior Advisor to the USAID Administrator, where he sees the development and implementation of USAID's COVID response efforts. The resource is approaching $10 billion to support over 100 countries suffering from the effects of the virus. He leads the USAID's engagement with foreign governments, partner organizations, and the global response institutions, including Gavi, COVAX, WHO. And he's rejoined USAID in January 2021. Previously, he'd been at USAID as the Director of Foreign Assistance in 2017 and 18. He oversaw their global programs and responses for about 70 disasters in 50 countries every year. He's also worked on the Ebola outbreak, the Nepal earthquake, the Iraq crisis, Typhoon Haiyan in the Philippines, the resurgent conflict in South Sudan, and the ongoing war in Syria. So he's got a large background, extensive background in crisis work. So wherever Jeremy goes, there's crisis. He's also serves as an independent oversight coordinator for the WHO program on health emergencies. He holds a bachelor's degree from Calvin College and a master's from Georgetown University and School of Foreign Service. From Uganda, we have Richard Lisimbo, who is a Ugandan LGBT activist, documentary filmmaker, and public speaker. He currently works as a program manager for Pan-Africa Lesbian and Gay Association and serves as the national coordinator for the Uganda Key Populations Consortium. He received his bachelor's in information technology from Uganda Christian University and a master's in human rights and democracy in Africa from the University of Pretoria. Our third speaker is Dr. Bongile Mabelane, based in Johannesburg, South Africa. She currently leads the medical quality improvement initiatives for the Inova Health Institute, which does both HIV and TB care and treatment. She's passionate about public health, bioethics, corporate strategy, health service management, and recently biotechnology. She serves on a number of national research ethics committees in South Africa, as well as serving as a deputy chairperson from one of them. She has over 10 years of clinical experience in both public and private sectors. And our final presenter today, panelist today, is Dr. Fabio Mosquito, who I've known it seems like since the beginning of my international career. Fabio is a medical doctor from Brazil with a PhD in public epidemiology, public health. He was recently nominated to be the WHO deputy head of the country office in Myanmar, where he previously served as team leader for HIV and viral hepatitis and is in charge of coordinating the partners working group for case management and control of COVID. He's been in the field for 34 years, working on HIV, STIs, and viral hepatitis. He was a pioneer in the response in Latin America and worked for the state of Sao Paulo and for the federal government as the former director of the Brazilian National HIV, STI, and Viral Hepatitis Department. Again, he's worked outside of Brazil for 15 years as part of the Australian Burnet Institute in Indonesia and 12 years in WHO. And before coming to Myanmar, he was a technical officer for HIV and the global program on viral hepatitis at WHO Geneva. So I'd like to invite Jeremy now to make some comments, and then we will move on to the panel discussion. Thank you very much. Jeremy, on to you.
Thanks so much, Billy, and good morning, good afternoon, good evening to everyone. Wherever you all are around the world, it is really a privilege to be speaking with you today. When Clint reached out to ask if I would do this, I was really eager to say yes, because I am a strong believer in the importance, even the centrality of local partnership in effective public health programming and effective outbreak response. You know, Clint has just been discussing the really the vital, even foundational role that local partners play in PEPFAR's support and in the wider fight against HIV. And I think what we've seen is that that is not unique to HIV. We have seen that the importance of local partners in so many different outbreak efforts and disease efforts around the world. I am most familiar with, excuse me, I am most familiar with the fight against Ebola, fights against Ebola now in West Africa and Congo and in other countries, and of course COVID-19 in my current role. So I've seen this so many times. In Sierra Leone during the Ebola outbreak in 2014, we saw over and over that communities that might resist taking some of the measures they needed to take to protect themselves would listen. You know, they would listen to local actors, local organizations, and credible local voices when they wouldn't necessarily listen to the government. They wouldn't necessarily listen to international partners or international organizations, but they would listen to local partners. And so we built a lot of our outreach efforts, but also a lot of our delivery efforts in the end around those credible local actors who were trusted by the community. We saw that in Liberia as well. We saw huge shifts in community risk mitigation during Ebola, when communities understood the risk and could take ownership of the fight. And I'm particularly glad that the panel that's coming up is going to talk about this, not just in terms of service delivery or aid program management, but also in terms of human rights and political challenges. That's a dynamic that we've seen firsthand in many places. We've seen during the COVID outbreak that COVID can sometimes, and the COVID response can sometimes get very entangled with local political dynamics or national political dynamics. And so it's really important to understand how those things come together. It's also a dynamic that we saw a few years ago in Eastern Congo during the Ebola outbreak there. That was a really complex setting with challenging politics, an ongoing and very violent at times conflict. And those political dynamics and those conflict dynamics were really integral to how the communities perceived the outbreak response. And that had the risk of undermining the success of the effort to control the disease. And so it was really critical to engage with and hear from local actors and local partners, the local partners that had the best links and the best understanding of those communities, because that shaped the whole understanding of how to effectively engage with communities in that context of conflict. And when we got that wrong, when the international support, the international actors got that wrong, what we found was communities would reject or would be hesitant towards the vaccine and some of the other outreach efforts. We also found that through that engagement with local actors, I think came to realize that the international effort was too reliant on security forces in ways that was really coloring and shifting the perception of the whole outbreak response, because it became to be seen as kind of securitized and politicized rather than about public health. And so, we needed that engagement with and through local partners in order to understand how to better engage with communities in a credible way. And these things are important for so many reasons, but one of the most central is that any outbreak response ultimately comes down to trust. What we are asking individuals and communities to do in an outbreak response, whether that's Ebola, whether that's HIV, whether that's now COVID-19, is to change their behaviors in some way, to understand risk and apply risk in their own lives and in their communities' lives, and change their behaviors in a way that mitigates that risk. And that is not something that happens easily, as you all know. And it's something that has to happen with and through credible local voices and credible local validators. And so we have been trying to build that insight into our COVID-19 response. We have worked with local partners in many countries. In Peru, we've partnered with a local NGO called Asociación Benefica Prisma to provide training sessions for healthcare workers on cold chain usage and vaccine administration. We've partnered with Inova Health Institute, and we're joined here by a colleague from Inova. But we partnered with Inova Health Institute to support mobile vaccination efforts. We've also, beyond the vaccine work, we've worked with local partners on global on oxygen provision. And so, for example, in Laos, we've worked with training of trainers on effective oxygen provision, which is one of the most life-saving interventions that's available to us on COVID-19. And so, I think as we now look forward, and we look forward to this forthcoming effort to vaccinate the world, and to get, as the president has said, to try and get every country in the world to 70% vaccination by next September. I think my message to you is we need you. We need you in that effort. We need the skills and the expertise that you bring on how to, your knowledge of how to deliver services in your countries and your communities. So we need to work through you. We need to work through your skills and your platforms and your capacity. We need to listen to you. We need to hear your local knowledge, your understanding, your perspectives on how can we reach out most effectively in the vaccine effort? How can we most effectively engage with and promote vaccine confidence? And we need your voices. We need your voices as trusted validators in your communities, supporting and promoting the vaccine effort and the safety and the importance of getting vaccinated. And so I am really thrilled that this gathering is happening. I'm really thrilled that the next panel is going to be looking at this interrelationship between outbreak response, trust, human rights, politics, this mix that really gets to the core of how people make their choices and how trust in a response is built. And so it's a real honor and a privilege to speak with you all today. And I can't thank you enough for your dedication and the work that you are doing every day, whether that's on HIV in your day jobs, or whether that's also on COVID-19 and supporting the adaptation to COVID-19 service delivery and supporting the vaccine effort as it grows over the coming months. So thank you so much.
Thanks, Jeremy. At this point, we'll go into the panel discussion, and I'd like to ask Richard to please go first. it's important to have boots on the ground perspective here, as Jeremy has said. So, Richard, you've spent the past year in COVID in an interesting situation where you've also had to deal with a presidential election during the middle of lockdowns in Uganda, as well as over the past couple of months, some terrorist attacks and bombings in your country. So, you know, this impacts on not just human rights, but the ability of people to pass messages along and gather. So I'm going to turn it over to Richard first, if you could.
Thank you so much, Billy, and also Jeremy, for those wonderful opening remarks. I really appreciate for the organizers for setting this up so that we can have a conversation around the issues that are affecting us while we are facing COVID-19. And of course, for years, we've been dealing and working around HIV. So when COVID broke out, as we all know, last year, there was not much preparation because no one knew what was happening. And the first thing that every government was doing was to save its population from the pandemic in any possible way as possible. And this led to lockdowns, or curfew, something that person of my age, I had never felt experienced in my entire life. Just waking up and you know you can't leave your house, you can't go to work, and you can't even access the people that you're providing services. Now that became a little bit tricky because at the very start of our lockdown in Uganda, 20 young LGBTI persons were raided, their shelter was raided by police, and they were arrested and they were put in jail, and they could not even have access to legal redress. And it's because there was no movement, and that was already a big challenge. And unfortunately, even at the same time, it was very difficult even to provide access to the ART because nobody was allowed to move and nobody was accessing nobody. So it became really a huge challenge that one, the emphasis was being put on protecting the population or dealing with the pandemic, while not also looking at the wider scope, and this greatly limited in terms of how do we deal with these issues. And also this also created gaps in terms of how we're responding to HIV, because then people could not move from one point to the other because of restrictions, because of the ban on the transport movement, and also private and public transportation was locked down. But also now quickly to look on the bright side of everything is that we quickly adopted the circumstances that we're now living in. And the first thing was engaging Ministry of Health in terms of having a human rights-based approach, and as they advise the executive or the president in terms of what measures should be taken in dealing with the pandemic, in terms of providing spaces to deal with other issues. And through this, we're able to at least have whereby services through health facilities were opened up, but also allowing community members to actually access art from any point where the lockdown found them. And that really also opened up, which also helped us for people having access to the services, but also ensuring that they're able to access their life saving medication. But also communities quickly adopted to what we famously call here as the social network services, whereby the peer system was strengthened. And now people started working with peers within their facilities, within their locale, and those peers had access to the health facilities, and also the provision of motorbikes and bicycles helped to facilitate the work of peers where we did not have access to cars because due to the lockdown measures. And this quickly pulled us from the gutters, whereby services were now starting to flow and opening up to the communities. And that was a great initiative, and also really looking at the engagement with the ministry and the Ministry of Health being very responsive and quick on what communities were saying really helped us to actually change the course of doing things. One of the other things was to really carry out huge campaigns through communities to ensure that one, they understand what were the repercussions if they did not follow the COVID SOPs. And we had this famous saying that do not touch men, which was mouth, ears, and nose. And that really helped to ease the communication, because then it was very easy for people to understand that then you need to mask up, you need to social distance, and also if you feel sick, then you need to speak out as soon as possible. But I'm also glad that while we have gone through that, and then we've also gone through the second lockdown that just happened a few months ago due to the second wave in Uganda, we are seeing a transition in the community really adopting. And we're so glad that right now the vaccines are also starting to be available. And we've tried as much as possible, because at the very start of the rollout of vaccines, there were issues around people living with HIV. Do they have to take the vaccines? Are they at the risk? And because we engage communities, we are seeing that now people are coming up to take these vaccines, but also we have also engaged communities to understand where to get these vaccines. But now also delighted that now the ministry has also acknowledged and has accepted where people go to get their refills, they actually can have access to vaccines. So again, this is easing the burden for people to move from just long distances to access the vaccines. The other thing we're doing is also identifying, for example, drop-in centers where people largely access now catching up with the mental health, and now vaccine are being rolled out in the drop-in centers in Uganda. This has really helped, especially around Kampala, Mukono, Wakiso areas, and Jinja within the country. And we're hoping that we can roll out this program across the country so that the vulnerable and marginalized communities can also still have access to vaccines. And we are hoping that really working together with government is one thing that will really help us to ensure that communities are able to access services as they should be. But I think as a closing word here, before I hand over back to Billy,
Recording in progress.
Together as partners so that communities can respond in a way that is important and listen to and also be responsive. Thank you.
Thanks, Richard. And it's always good to hear about how people in the community are working together with the government to address both HIV mitigation as well as rolling out using yourselves as a platform and your connections in the community to roll out services. I'm going to turn to Bongile, who is trying to deal with the dual pandemics in the country that has the largest number of HIV positive people in the world, and has also been faced this year with some economic disorders and civil unrest in the country. So Bongile, I'll turn it over to you to look at your observations. Thank you.
Thank you so much, Billy. I will start with saying good afternoon, buenas tardes a todo el mundo, and thank you for having me today. It's such a great privilege and a pleasure to be sharing the platform with such distinguished panelists. I think it's very true that we are still struggling, and I think when we talk about dual pandemics, in our case, we have quite a number. I'll focus on COVID for today, but I think just to flag that we had COVID, I think the past 18 months has been a big COVID hit for us. But I think secondly, in South Africa, we are starting to experience a lot of changes with our climate and just climate change we had the largest rainfalls, we had the coldest winters this year, and all of that, I think it impacts on just the mobility, the health, and the dynamics of our community health. I think, again, I think it might have been this year around July, we had a huge political unrest and riots just that came out of nowhere. It disrupted our services, both in the clinics and just our normal lives. And I think that's starting to pop up. I think also this year, our president announced that gender-based violence in South Africa is a pandemic. And it's really affecting how we are seeing different kind of impacts from those from that pandemic alone. And I think if I can just quote the fifth one, I would classify it under emotional fatigue, ethical compass, that we're starting. I think it's not something that COVID introduced, it's something that COVID shifted with our workforce and our staff. I mean, just generally, and we saw quite a lot of unrest during the COVID period. So we did have a lot of pandemics on top of COVID, where just, issues around PPEs would just cause a standstill in our clinics and hospitals and so forth. But just to concentrate on COVID and how we've been able to adapt, it really took a huge knock. I think if we look systematically at the first 90, second 90, third 90, our first 90 was the one that really took a huge knock. Just us getting testing services to the people and for the people to come to the clinics. And I think really at the beginning, when I looked at this problem, I really wanted to box it. I think as you've introduced, quality improvement, which is just so systematic, everything has to have a box. And we looked at what exactly is happening with this COVID HIV, and specifically for the first 90. And we grouped it into what we called a harvest project, basically how to turn that around. And the harvest project, the H for that stands for the head count. We realized quite early that the head counts in our clinics and even our hospitals had taken a knock. And the second, the A, there was the attention. All of the attention was just redirected to COVID. And I'm talking political attention, I'm talking administrative attention, economics, but we basically just left HIV somewhere, and we focused on COVID, which was quite a response. There are stands there for referrals. So early in the pandemic in South Africa, the community teams where we are working were redirected to respond to COVID. So they did door-to-door, they did mask, education and so forth. So referrals from our local partners where we normally get our patients from, that pool completely went dry. The V stood for our VCT spaces where we normally test. So what happened is that clinics chose to take services outside to mitigate COVID exposures to the staff. And them taking the services outside meant that they were using a lot of our tents, a lot of our gazebos, which normally if you come to South Africa, the ANOVA tents is what you normally see as our testing spaces. So that was compromised. So meaning that even if we had the test kits, we didn't have spaces to test that, we provide confidentiality and privacy and so forth. And the E was just the emotional stress on our patients, on our staff, which really, even if a nurse is working that day, they really aren't giving you 8 hours. They're really not giving you, the normal output that we had expected. Just three more. The S stood for just the service point and the clinic closures that we experienced in the beginning. We really didn't know in the beginning whether, when you had a COVID exposed nurse, do we close everything down? Do we shut down the clinic? When do you fumigate? When do you not fumigate? And so I think we had a lot of service disruption just on navigating the protocols and the SOPs. I think as Jeremy has said, it was really a land of unknowns in the beginning. We didn't know whether, do we continue the service? Do you close the clinic down and fumigate and sanitize? We didn't have those protocols in place. And so that really shifted our service and so forth. I think the last one, which is the T, is something that really is underestimated, but I think it's quite important. The time away from work that we saw during the COVID times really did impact the well-being of our staff, but even just the normal allocation of services and issues. And so one could ask, how did we bounce back? I think for somebody maybe who is listening and they are probably in their second peak, they are in the third peak, fourth peak of COVID, and they are seeing their numbers a bit skewed up. I think this matrix for us was something that was very systematic to put together to say, let's put interventions and very clear interventions on the different aspects that I've named. I'll make a few examples with the head count. That was the first big elephant in the room for us. How do we get people to test again? And we had two options. We really said it's either the numbers of how we are even counting our head counts was miscued. With the services being disrupted, it even disrupted how we counted patients, how we collected our data. And we needed to quickly regroup ourselves to say, are there easier ways for us to collect data and so forth? And I think the other one is to use local partners, is to use your clinic committees. We really had to advocate and to put the word out there and to advocate for clinics to be open, to really render all the services and not just pieces of services that patients needed for the clinics to be open. And once that trust and confidence came back, patients were much more comfortable to come back to the clinics and attend to their services. I think it's a whole lot of list in terms of what interventions did we do, but I think each advocacy for me is what ties everything through. The attention from the departments and from the political sphere to go back to HIV was a pull that we had to do by advocating that services are not being rendered the way we should. And I think all of those things, I think, were part and parcels of how we quickly adapted to COVID and how we are able to now at least have some bit of resilience. We've passed through second wave in South Africa. We've just gone through third wave, and we are grateful for the vaccines that are being rolled out. But we know that from the data, I think there is some level of resilience, especially in the first 90 that we're starting to pick up, just because we were very intentional about putting all our advocacy tools as local partners to really push that the harvest comes back. I'll hand it over to you.
Thanks, Bongile. As usual, very insightful presentation looking at, crises that we hadn't talked about, like climate change. And there's a meeting going on in Geneva. It's much easier to deal with sickness in front of us than sickness in a planet that's sometimes harder to see for people in other places, as well as the mental health issues and how those all tie into sickness, economics, service provision. I think that's something we might want to come back to, sort of like, at what point do we have enough resilience, or what can we do to support our mental, emotional resilience to deal with multiple pandemics as they keep hitting us. But thank you. Brilliant presentation as usual. And next we'll go to Fabio, who's in a country who he said this morning, Myanmar has been like 3 different countries since I got here. I came during a democracy, then COVID hit, and now I'm living under a military dictatorship and civil war. So Fabio, please, if you can articulate some of your experiences in the past year in both the COVID situation and as what happens when you have a coup, a political military coup, and it affects national and civil unrest, and how you deal with COVID and HIV on top of all of that.
Thank you so much, Billy. Good morning, good afternoon, good evening all. It's a pleasure to be here. I'd like to thank to USAID for this invitation. And also thanks especially to Billy that already mentioned that we are old friends in the field of international health for years. And also I'd like to thank to Courtney Irving, who was part of the people that invited us for this presentation. It's a pleasure to be here and join this panel with Jeremy, Richard, and Bojil. It's very impressive, all the says before my speech. And just a very short disclaimer that I'm not speaking on behalf of my organization, but I'm speaking by my experience in these last 3 years, in particular in the last year. So as Billy said, I think I'm living in Myanmar for 3 years, and my experience here is being like if I was in 3 different countries. So the first year with the civil government, no COVID. The second year, a big first and second wave of COVID. And the third year, the military takeover plus COVID. So was a lot, I would say, in terms of challenges. For the HIV, I think we reacted very fast during the beginning of the pandemic in 2020, developing a contingency plan. This contingency plan by the time was agreed with the Ministry of Health, by the time was called Ministry of Health and Sports, was led by us and UNAIDS, and USAID was engaged from the beginning, together with many other partners. And our work was basically to guarantee that the people living with HIV get medicines for 6 months. We could do prescription for 6 months. And we also could guarantee, like considering that the epidemic in Myanmar is a concentrated epidemic in key affected populations, and the population at most risk and the highest impact of HIV is related to people who inject drugs. We are in a country that's the second main producer of heroin in the planet. Heroin here is very cheap, very easy to find, and very good quality, is produced locally. And therefore, there is a big challenge in terms of injection of drugs for people related to HIV and related to viral hepatitis. The main impact, the main affected in the 2020 is basically the prevention strategies overall, but in particular outreach work, in particular testing, and in particular prevention. And I'm saying that because like we could keep somehow the treatment, we could keep somehow methadone maintenance treatment, but we lost in terms of prevention. It's very important to say that we have a long-term relationship with USAID in the country, even before 2020. Like together, we worked very hard for a better local adapted concept of trans people. Curiosity, Myanmar never had this definition. Used trans people was classified and registered as men who have sex with men. And so this effort that was very pushed by our colleagues from USAID had our support, and it was very important. Another front that we worked together that was very crucial for the country was Buprenorphine as an option to methadone, not excluding the importance of methadone, that's still the priority in terms of drug treatment, but Buprenorphine as additional tool to treat more people is an important thing. Self-testing was another one, and that was crucial after the testing was impacted by the COVID-19. People could not circulate because of the lockdowns, because of the curfews, because of many reasons in 2020, and self-testing became a good, important strategy, and the USAID was important in that leadership. Also, USAID, through the PEPFAR, was a very key partner for PrEP promotion, which was new for the country. I remember I arrived here, was one of my first debates in the country about the importance of PrEP in prevention. So just to have a figure, Billy, it may be interesting to show that in 2019, we have had 184,000 people under ARV. In 2020, 199. We could grow even during the COVID pandemic in 2020, but then with the military takeover, the conflict that increased and everything that became more complicated, besides the third wave that was the strongest one in the history of these 2 years, basically we got down to 141,000. So we lost more than 55,000 people under ART due to the political plus the third wave of COVID that was really over, right? So in terms of methadone, the same. We used to have almost 20,000 in 2009, get to 26,000 in 2020, even with the wave 1 and 2 of COVID. And then we lost for 24,000 in 2021. Less impact than ARV, but still important. So then basically, like, we have many challenges, and the last challenge we tried to develop a Myanmar HIV Interim plan that has an interim coordination mechanism that WHO is part of it, and USAID is part of it, and UNAIDS is part of it. And this interim mechanism is trying to find ways to keep the distribution of antiretroviral therapy. It starts through mainly through NGOs to our local partners that I completely agree with Richard is the very crucial piece of it, right? And also what Jeremy's mentioned. So with local partners, with international NGOs, we are trying to get the work in place and to keep whatever we can in terms of distribution of ARV, in terms of drug treatment. So those are the initial thoughts, and I will be happy to say anything else if is necessary. So thank you very much, Billy, again.
Thanks, Fabio. Appreciate your insights as always, and you are really working in one of the more challenging operating environments, and I think we'll get to a few more insights about that, particularly in areas outside the capital or controlled by the government. So we've got a few questions for the panel. So one of the first questions comes from Prosper Sabagenzi for Richard. Richard, thanks for the clear presentation. So the question is, did people in Uganda welcome COVID-19 vaccines, and were they accepted without any resistance about getting vaccinated? Was there any vaccine hesitancy in Uganda?
Thank you so much for the question, Prosper and Billy. One, I want to say that in Uganda, there's a lot of faith in our Ministry of Health and science. So that has really helped not to have lots of concerns around the vaccines. The only challenge we've had was actually having the availability of vaccines. But many Ugandans are ready and have been willing to actually take on vaccines. And unlike other places, there has actually been a high uptake of vaccines by the young generation or young people, because recently even the Ministry of Health was saying they're concerned that people over 50 years and above were hesitant in taking vaccines, yet they were the ones who were at the forefront, given the fact that 58% of Uganda's population is 18 years and below. So really, there's been a lot of acceptance of uptake of vaccines. And currently, as of the results shared by the Ministry of Health, So far, we have vaccinated as a country 3,108,173 Ugandans who have been vaccinated so far. And I think one of the other things is that Ugandans are embracing vaccines because we are tired of being locked down. So we want the economy to open up, we want to freely move around and enjoy our country. And that's one of the drives that is actually really helping people take their vaccines, but also because there's been a lot of political will from the president and all political leaders really working together to ensure that they sensitize masses, religious leaders, cultural leaders. All stakeholders have really been speaking and encouraging Ugandans to take vaccines, taking the vaccines in public to ensure that they encourage people who follow them, like cultural leaders, religious leaders, and political leaders, so that the masses know that even their own leaders are taking the vaccines and they are safe. So that has really helped not to have so many resistance or issues in Uganda in terms of uptake of vaccines. Thank you so much.
So just a follow-on question from Olufemi. Okay, and this is also on the vaccines. You spoke about using ART sites and drop-in centers for vaccine uptake. How were you able to handle the vaccine cold chain and supply chain to preserve the effectiveness? Obviously working with government and Uganda medical stores, but how did you do that?
Yeah, so the Ministry of Health has really been working with different stakeholders, and I really want to take this opportunity to appreciate the support we're receiving from the American people through USAID and also PEPFAR at large, who have also provided resources to really boost the supply chain of the vaccines in the country, and also working together with the Global Fund. There's been also purchases of more refrigerators, which have vehicles that are mobile, which has really boosted in terms of how the medical stores can really move the vaccines across the country. And of course, working with different partners from USAID, they have also availed their facilities, which are also providing support to the Ministry of Health. And this has really helped us to really start moving across the country, because one of the issues at the very start was how are we going to be able to move the vaccines across the country? How shall they be stored? But with all these partners coming on board, this has really helped us to deal with those challenges.
Thanks, Richard. Bongile, a question for you from Felix Iwala. Thanks for a great presentation. He would like to know how your team addressed the economic and nutritional needs of PLHIV when there were, during lockdowns and shortages, periods of shortage that happened in South Africa during the COVID epidemic.
Wow, that's a great question. I think so there's two things there. I'm hearing nutrition, I'm hearing economics. I think on the nutrition part, there might not be a lot from our side directly, but as a response from the government, there was a COVID stipend that came from the COVID fund, the national fund, and I think that was tailored for not just persons living with HIV, but all unemployed citizens that were 18 and above could get that bit of money just to cushion the impact that COVID had on families. But I think when I tie back the economic part, maybe there's two things that we really looked at it, and we knew that patients are spending money on two main things. Patients are spending money coming to our clinics, that means transportation, and patients are coming to our clinics to collect treatment. And so for us to mitigate some of those economic impacts, I would say that the first thing for us was to really strengthen same-day treatment. And our linkage during that time was at our all high. So no patient could be given, come back after 7 days, come back, because there was no transport for those patients to come. So really moving and accelerating our teams to really do proper and full counseling, and to get the patients ready for same-day initiation, and really integrate all of those services so that the patient doesn't have to come back for further visits, and so that cushions them a bit. I think the second initiative that I'm really proud of is the part where we really integrated ourselves internally to make our community health more integrated, meaning that our communities just didn't come there with just HIV, but we started screening TB, we started screening for COVID, we started giving patients dates for pap smear. So the integration of patients really coming to the clinics was really reduced. And I think lastly on this part was on the part of decanting. I don't know what it's called in other countries, but we call it CCMDD. It's a decanting project for those who are virally suppressed. We had a target. We literally tripled the targets of patients that we can decant. And so we went back to our data sources to say how many of those patients are virally suppressed and how many of them can be decanted. And those who were decanted, we pushed from us just giving them 3 months treatment to actually 6 months, and in other cases, actually even 12 months treatment. So those patients had treatment and there was no need for them to travel all the way to our clinic. Some of them are really far in the rural areas. So I think those are some of the, I can say, local interventions that we did to really address some of the plight that the patients were facing. Thanks.
Thanks, Wongile. There's another question from Dr. Felix to Fabio. He would like to know your experience with using HIV self-tests in Myanmar, particularly, and I guess WHO overall, since you were the technical advisor in Geneva, in terms of stigma and discrimination, particularly when clients can't get to a testing center or there have been lockdowns, so outreach is a bit more difficult.
So thank you very much for the question. I think it's a very interesting question and important. Like for the case of Myanmar, this was like the way to escape of most of the facilities after the political crisis. Most of the facilities in the health sector were closed. The health sector was one of the most important movements against the resistance to the military takeover. And because of that, 80% of the doctors, laboratories, nurses, they stopped work. So then we have a very hard time to find places where people could be taken care in everything in health, including HIV and COVID. Laboratories already had challenges in 2020 because like all the PCRs machines that we use for viral load for HIV were dedicated to COVID. Like there was many challenges during all this time, but of course got more complicated when the health sector stopped work, and therefore self-testing started to be used by NGOs, national and international, in the way they could deliver somehow, and the people got completely trustful of their partners, because as local people, the majority of the international and national organizations, they speak the language, they know the people, and so the reactions were very favorable to the self-testing. I think was a challenge, of course, but was a good solution in the other hands. Thank you.
Thanks, Fabio. We have a question for all the panelists, and each one of you can answer this about your country. What's your experience in terms of sensitizing PLHIV to accept COVID vaccinations? And also, what kinds of vaccinations, I think, are you using? The single dose or multiple dose, and how does that impact on demand creation and access? So sort of three questions there. the difference between multiple single-dose vaccines, maybe even Chinese versus Western vaccines, and sort of how are you sensitizing people with HIV on accepting vaccines and getting rid of the hesitancy in those communities. So start with Fabio, and then Bongile and Richard.
So thanks, Billy. Some of the vaccines in Myanmar, all of them that are in use at this point are approved by WHO. We have basically the majority of them are Sinovac, Sinopharm, but also we have the AstraZeneca vaccine that was in fact the first one who arrived to the country. We didn't got yet Pfizer or we didn't got yet Johnson. The Johnson, actually we got a little bit of Johnson to vaccinate the international NGOs and the UN staff, but we are still waiting for the approval of the FDA that did not approve yet for use. So we received it in the country, but we couldn't use at this point. For people living with HIV, the country did not put as a priority population like other countries did. So depending on the country, this policy was different over the world. But like in my country, Brazil, people living with HIV is priority. Here is not under the priority of people who needs to be vaccinated. Anyhow, we promoted a lot of vaccination among people living with HIV. We know that WHO describes something that happens on the COVID crisis as infodemic, the information epidemic. And in the information epidemic, there is a lot of fake news and wrong information about vaccines and HIV. Recently, we heard the president of Brazil saying that people who takes the vaccine can get HIV because of that. So one high authority saying that. So this kind of things are confusing all over the world. And our main work is being to clarify those things, to put every time advertisements in the WHO web page, the WHO Facebook. Facebook here is the real way of communication among people in Myanmar. But despite that, we have some regions where there is no electricity, no internet, no communication, and then we are printing materials with all this clear information to make sure in all the different languages that are around the country to make sure that everybody has the correct information as much as we can. So I think that is our approach at this point. Thank you, over.
Bongile, South Africa had some issues with AstraZeneca, I believe, at one point.
Yes, we did, and we were so excited that, you know, I think it was pulled off last minute. So we are using Pfizer for the greater part of the population. I think the approach in South Africa was we started off with Johnson & Johnson, which is just one dose for the essential workers. And essential workers was mainly the health sector. Then it was the education or, you know, your schools sector, and it was the police service. So those were the main essential workers. And after that group was done, we moved according to the age groups. So we know that with the risk factors of COVID, the older age groups are very much vulnerable. So yeah, and I think they got Pfizer most of that category of group. I think that the second part of that question is how were we able to convince patients to take up the vaccines? And I think there's a number of things, but I think the one that I got personally when I went to one of the visits recently, what really convinced patients to take up the vaccine was actually the fruits of a vaccinated health workforce. As I mentioned in the beginning, the disruptions that we had in a week, just to put it in perspective, maybe in a week we would have in a region maybe 10, 12 clinics closed because there's a COVID outbreak, there's a staff that's infected. But the minute the staff really was vaccinated, the number of infections really came down, and the stabilization of the clinics and the patients seeing that services are back to normal and healthcare workers are healthy again, and there's fewer admissions and there's fewer deaths. That alone, I think, has spoken volumes to a lot of the patients out there, and I'm seeing that observation from their side, that service delivery being stable and being consistent, is a testimony that the vaccines are working. We still have a group that still needs convincing, but I think the department and as local partners, we are looking at innovative ways through social media to really advance that message. But I think evidence is just on the testimony of how we were able to stabilize the services back.
Thank you. Richard, Uganda?
Yeah, thank you so much. Quickly, I'll just say that Uganda, the widely accessible vaccine is AstraZeneca, but now we are seeing Moderna and Pfizer also coming in, and also Chinese vaccine and Russian. So we are seeing that there are more vaccine coming, and also recently from even our own government purchase, we accessed Johnson & Johnson. So we are seeing a lot of diversity in terms of the vaccine coming up, and I hope that the access to vaccines accelerates so that countries like my country, Uganda, are able to have the vaccines to vaccinate the population that they need to. And then when it comes to, in terms of PLHIV, just as Fabio said, the very sad PLHIV was no, people were not put as a priority or as essential, but at least we are seeing that that's opening up, and the fact that they are really, the ministry is actually working together with partners to ensure that at centers they're administering vaccines. So that's a very good change, and an improvement. And in terms of really why and how the different accessibility of vaccines can also impact in terms of demand creation, I think one is people, yeah, of course, everyone would want to go for just one vaccine, just one jab, and then that's it. But again, we're talking about issues of availability of vaccines. So this, in a way, has helped to really hold the people in terms of what they should demand for. And now it's about what is available and what can save our lives. And that's how we're looking at things. But maybe just want to highlight one thing that also was a little bit of a setback in terms of the vaccine drive, was when different countries in the West started to actually not acknowledge people who are vaccinated from countries like mine, and yet the vaccines that we're getting as donations and support were coming from their countries. So that alone also, in a way, was a big blow to how we are pushing for mass vaccination in our countries. Thank you.
Thanks, Richard. We've got about 4 minutes left in this session. And I want to take a little bit of prerogative here. So a couple minutes on each. Bongile, you had brought up resilience and mental health, both for providers and patients. In the last 4 minutes, can each of you take a minute and think, how can we continue to be resilient in the face of multiple pandemics? I know that's a really heavy question, but but I know you've all thought about it. There are only so many crises one can face before, or are there? What can we do to keep facing multiple crises? So I'll start with Bongile, Fabio, and give Richard the last comment.
I had wanted to throw that to Richard, so let me start first. But I think it's such a heavy subject, and I think for me it's safety first. How do we get to safety first? And I think safety first to me is you are safe I think I go back to the famous quote, I don't even know where this comes from, but I've heard that hurt people hurt others. And I also believe that a healed person is able to transfer and create a healing environment. And I think for me, safety first, meaning that you need to be so okay, you need to have parameters in place. And I think in terms of COVID, the legitimate factors that did push our workers overboard in terms of not having enough PPE, working long hours, is safety issues. And I think when the government really does put resources in putting staff in environments where they can work safely and render safe services, I think that's already a buffer for us to have a healthy mind. And then once we are working in well-resourced environments, I think having available access to resources that will be able to speak to different realities of depression, of fatigue. It can't just be one language. I think we need to really start pulling from different societies and experiences. The way that Richard and Fabio might see depression might not be the way that I see depression. So I think, I don't know how and where would that be centralized, but I think there's only just one counseling, one narrative that's coming to say, go out there, serve the people. But I do think that we need resources and to start pulling from different places. But for me, I would say really safety first, and the governments to work with local governments and departments to make us safe, to render safe services. And I think once the environment is safe, for us to be healed enough, for us to really transfer healing to our patients.
As usual, words of wisdom from you, Vangeli. I just love listening to what you have to say on these subjects. Fabio?
Yeah, okay. Today is a special day in one side of the world, because in the Catholic religion, today is the Dead Day, right? Is the in Mexico is a very important celebration, but in many other countries, like it's a special day on that sense. And I just wanna to pray my attention to all the health professionals that lost their life, but with the expectation that with vaccines, we are seeing that people has got more enthusiastic, more optimistic, and we have a great chance to recover this engagement and this commitment to save lives. Thank you very much.
Thanks, Fabio. And Richard, last word, would you like to have?
I just want to say that we have learned a lot from HIV, and I think if we pick up those lessons, we shall deal well with the COVID pandemic and any other pandemic that will come. If we put the communities at the center, not on the sidelines, we will be able to fight any pandemic that comes, but also always prioritizing the wealthy countries or the wealth populations as opposed to the poor. Again, it doesn't solve anything. I think we should deal with pandemics as one global space as opposed to segregating ourselves into we are rich and we can buy everything out and then we can decide to give you vaccines in future. I think that still puts us as a population of the world at risk. So let's not forget that we need to always work together because we've learned a lot from HIV and those lessons still apply even in this world today. Thank you.
Thank you. And I'd like to thank all the panelists. These three people on here and Jeremy, I actually love being on panels with these people because I learned so much about what's going on in the field. And I hope you have too. We'd like to wish you a great day. I'd like to thank everybody for attending. And I believe that's it. Thank you everyone for a fantastic session. And we'll talk to you guys soon. Cheers.